When a child begins to drown, every second counts to save their life. It's why one Bay Area Fire and Rescue Department has developed a new rescue approach. Parents, you really need to watch this. 10 News Polk County newsroom reporter Marcus Grayson shows you how its unique technique is saving lives.
Catch it, run!
Destiny Pitts says playtime is something she does not take for granted anymore.
You think you watch your kids enough?
When her son Landon fell into the pool back in March, it changed her life.
He was blue when I pulled him out and lifeless on the ground.
After arriving, the Polk County Fire Rescue used a new life-saving technique called the hand-heavy method.
And then you're kind of fumbling around with tapes and fumbling around with looking up doses.
He got in the pool and he was drowning.
The hand-heavy method is immediately deployed after 911 operators give first responders key information. While traveling to the scene, these rescuers are preparing using the new method.
Here in Polk County, when a first responder arrives on the scene of a drowning, they know exactly the dosage of medication they should give to the child. Dr. Banerjee says that information is a game changer.
We can try to give you every possible chance to give you a good outcome.
Polk County says in 2012 and 2013, before the hand-heavy method was used, the county had a 0% survival rate among pediatric cardiac arrest patients. But in 2014, the method was implemented and the survival rate jumped to 71%. And since January of this year, the survival rate risen to 78%. Destiny says she's got all she wanted for Christmas.
Keep on moving on with life.
In Eagle Lake, Marcus Grayson, 10 News, WTSP.
Hi, everybody. This is A.J. Heitman, Editor-in-Chief of JEMS, and welcome to today's webcast from 0 to 35% survival, new advances in pediatric resuscitation. In this webcast, sponsored by Laerdal, you're going to learn how Polk County, Florida Fire Rescue redesigned their pediatric and neonatal resuscitation practices and went from 0% to an amazing 35% survival to discharge. It's truly epic work. It's going to be highlighted in some major publications soon, and it's great that you're getting the first look at all of this.
Hello, this is Lance Taylor, and I'd like to talk to you today about the Lakeland Fire Department's adoption and implementation of the hand-heavy system when providing pediatric medical care on scene. As many of you know, all paramedics at the department received extensive training on the hand-heavy system earlier in the year, and it's actively in use. The new hand-heavy system is different than how we have treated pediatric patients in the past, and I'm here along with fellow hand-heavy instructor Derek McBrayer to remind everyone that the new hand-heavy system creates better results for the patient. But it's important to trust in the process and become comfortable in how it may play out on a medical scene. It is very important to keep in mind that you will spend more time on scene providing life-saving care then and there when possible, rather than picking up the patient as soon as possible and sending them to the hospital. This extended time on scene may make some EMTs or traditionalists uncomfortable, but we're here to assure you that it's okay. Become comfortable allowing the paramedic at the scene to control care provided. As a reminder, the hand-heavy system employs the following methods on scene. As a result, it may create extended times on scene. However, we believe it will create better outcomes for our patients based on the latest studies on pediatric patient outcomes.
When using the hand-heavy method, it's critical to accomplish 5 benchmarks before transporting the patient. These 5 benchmarks correlate with the first 5 letters of the alphabet. A stands for arrive. Arrive includes the pre-arrival information included with your notes from the MDT. This hopefully gives the age so that way you can determine the weight of the patient. In addition to the weight of the patient, it is important to assign crew members specific roles prior to arrival so that everyone is on the same page. The B stands for BVM. Statistically, most pediatric cardiac arrests originate from respiratory distress, so it is critical that the airway be controlled early. This includes intubating the patient before transport. C stands for compress. The heart must be primed in order to restart. Providers must remember to provide adequate compression depth and at a rate between 100 to 120 beats per minute. D stands for drill. For the reason that pediatric patients are difficult to gain intravenous access, it is advised to utilize the intraosseous needle initially instead of trying for an IV. E stands for epinephrine. While there is no definitive evidence to support the timing of epinephrine administration and pre-hospital pediatric cardiac arrest, there is a correlation of lower return of spontaneous circulation numbers in patients who received a delayed dose of epinephrine.
You should always bring whatever equipment you may think you need. If in doubt, bring it. But 100% of the time, you need to bring that hand-heavy kit. We all know that the hand-heavy kit is on 100% of our Lakeland Fire Department apparatuses, and you need to bring it on scene 100% of the time, because we can't always rely that other agencies we're with bring the kit with them. So we need to always be prepared to provide the best service for the customer.
I believe it's just a new system that makes it easier to train, our individuals to be able to work on children better. But as far as my role on scene is concerned, it hasn't changed any. I'm there to hold security on the scene, to make sure my crew is safe, to make sure my crew's doing the proper thing, to interact with the individuals on scene, the family members, to try to calm them as much as possible. I'm also there to take direction from my paramedic should he need any assistance at the EMT level, from spiking bags to setting up 3 leads to taking blood sugars, things of that nature that I'm allowed to do while on scene.
We appreciate you taking the time to listen. With summer upon us and an increase in calls like pediatric drownings and pediatric cardiac arrests common with children being out of school, having this system to rely on couldn't come at a better time. Trust the process, believe in the system, and as Dr. Handtevy himself reminds us to think, restart the heart before you depart.
We'll illustrate why it's important to determine the cause of cardiac arrest because of the possibility of family genetic diseases, and demonstrate optimal strategies for survival in pediatric arrest. A couple housekeeping notes for you just before we get started. This is both live and interactive, so you can ask questions at any time by clicking in the Ask a Question box in the presentation window, then click Send. The presenters will answer questions during the Q&A portion at the end, and any technical support questions will be handled by a member of our technical support team. You'll be able to download a PDF of the slides by clicking on the Event Resources tab. Also, if you're running any pop-up blocking software, you'll need to disable it to view this webcast. And in addition, it's recommended you close all other applications for better performance. At the end of the webcast, there'll be a short survey that's going to appear on your screen. To receive an hour of CAPC-approved CE, you must complete that evaluation. Instructions on how to attain your certificate will be emailed to you in 3 to 5 business days following the webcast. And ConNet is only available for those who are attending the live event and is not available if you're watching the archived event. So get your certification number out. You'll need that at the end, and hang around for a couple seconds and fill that out so we can get you CE credit. For your convenience, this webcast will be available on demand within 24 hours of this live event. A reminder email message will be sent to all registrants with a link to the archive. It'll also be archived at jems.com webcasts. I'd like to thank our sponsor, Laerdal, for supporting today's webcast. Laerdal is truly a leader in resuscitation with special corporate and staff interest in improving pediatric resuscitation, so we're thrilled that they sponsored this. And now it's my pleasure to introduce our speakers. You're going to hear from Lisa Carell. She's Captain and Training Officer in the Office of Medical Direction at Polk County, Florida Fire Rescue. Ralph Vitone is the Deputy Chief of Emergency Services at Polk County, Florida Fire Rescue. And our introductory speaker and our closing speaker is going to be Dr. Paul Banerjee. He's the Medical Director of Polk County Fire Rescue. He's also involved with the Polk County Sheriff's Office SWAT team. Lake County Sheriff's Office, Lake Technical College EMS program in Florida. Also serves as Associate Medical Director for Osceola Regional Medical Center. He's board certified in emergency medicine and associate professor in emergency medicine at the University of Florida, Central Florida, I should say, School of Medicine. And he's also a very valuable member of the JEMS editorial board and a member of the Major Municipalities Medical Directors Coalition, aka the Eagles. So with that, I'm going to turn it over to you, Dr. Banerjee, and thanks so much for your effort and everything your department is doing. Go get them.
Thank you, AJ. So let's begin. What we're going to do is I'm going to go over the cardiac arrest situations that we have and tell you how scared we were when this first started. And I just can't imagine I'm talking about cardiac arrest, about pediatric cardiac arrest, especially 3 years ago, which I really didn't understand as well. So I think it's a great learning curve. We can all become really very good at this. It just takes a little bit of patience and understanding. But in general, pediatric cardiac arrest, there's about 5,000 non-traumatic pediatric out-of-hospital cardiac arrests a year. And the survival rates are really low, but less than 9%. And over the last decade, there has not been any improvement. The number one cause of death is respiratory failure. That occurs 70 to 80% of the time. And basically, the whole process evolves in that there's a cardiac arrest, there's a cessation of oxygen delivery to vital organs, asphyxia develops, which causes multi-organ failure, which results in anoxic brain injury and ultimately patient death. If you look at the data, the data from the Sudden Cardiac Arrest Foundation from out-of-hospital cardiac arrest, adults, pediatrics, different rhythms, EMS, the numbers are actually even worse. So we're not doing something well nationally, internationally. So are there things we can look at differently in how we approach pediatric arrests? If you look at the CARES registry, the survival rates done in the United States, survival is 8 per 100,000 cases. The incidence is 8 per 100,000 cases. Survival to discharge was 6%. 13% of EMS runs are for pediatric patients. ROSC rates varied from 2.5 to 34.7. And survival to discharge ranged from 2.6 to 14.7%. Now, normally everyone's kind of doing ACLS, PALS, tape measure, and we're not doing a really good job overall. Are there other things we can look at that we can do to improve on these numbers? So if you look at the cause of death, which is respiratory, and asphyxia is the number one cause of that, there's 5 major causes for asphyxia in cardiac arrest. There's hypoxemia, hypercarbia, metabolic acidosis, bradycardia, and hypotension. So the common theme here is what I want you to all understand is the whole thing is related to a hypoperfusion state. So in pediatric out-of-hospital cardiac arrest, the top causes that we're going to run on are sudden infant death syndrome, traumatic, drowning, poisoning, choking, severe asthma, and pneumonia. There are 5 critical factors in pediatric survival, and this is from the Journal of Circulation in 2012. It's number 1, it's the duration of the no-flow state, and we'll cover what that is shortly. Your initial ECG rhythm, the quality of BLS, ALS that's administered, your environment. In Florida, we're warm. I know a lot of you there's snow there, so again, different environment, and what pre-existing conditions are there for the child. So Circulation in 2014 published a PALS in-hospital cardiac arrest data set, and they studied since 2001, survival to discharge for pediatric in-hospital cardiac arrest has improved significantly. And this is interesting, especially because the patients who are admitted have much higher comorbidities. They have terrestrial flow, they have a whole bunch of cardiac anomalies that occur, but their survival rates are better. The ROSC rates of the last 12 years in the study went from 39 to 77, and survival to discharge improved from 24 to 43%. However, survival from pediatric out-of-hospital cardiac arrest has not improved over the last 5 years. And in general, why do you think that is? The study found there was 8.3% survival to discharge in all age groups. This is on the ROC trial. and they found that the 1-month survival with a CPC score, which is a level of neurological functioning, kind of like the Rankin score that we use in stroke, without ROSC is extremely low, less than 1%. So how do we determine neurologic survival outcomes in adults, and how do we do that in kids? Because the ultimate goal is, although we're getting the child back, we want to make sure they're neurologically functional or back at baseline prior to the event. So its pediatric outcome assessment is called the Cerebral Performance Category, the CPC, which kind of assesses neurologic outcomes after arrest. And the optimal survival following sudden cardiac arrest requires heart and brain resuscitation. And although anoxic brain injury is variable, this kind of measures how severe the damage is. If you have a CPC score of 1 or 2, basically you have good outcomes, CPC of 3 or greater, or very unfavorable outcomes. And this is the breakdown. Similar to the Rankin score, you basically have a CPC of 1, which is good, 2 is moderate, and number 5 is brain death. So our goal post-resuscitation is always to have at least a 1, at worst case scenario 2. Comparing out-of-hospital arrest and in-hospital arrest, there are some major differences. Primary respiratory etiology in out-of-hospital cardiac arrest, ROSC rates are less than 20%, survival is less than 9, poor neurologically intact patients, rarely witnessed, unknown downtime, and poor bystander CPR rates. And the opposite in hospital, because the ROSC rates are higher, survival rates are higher, obviously they're on monitors, so they're witnessed, and CPR is initiated immediately. So to keep perspective, although the in-hospital arrests have improved survival, pre-hospital, out-of-hospital cardiac arrests have not and remain dismal. So to understand pre-hospital arrest a little better when it comes to pediatrics, we looked at the 4 phases of cardiac arrest. And that's the pre-arrest phase, the no-flow phase, the low-flow phase, and the post-resuscitation phase. The pre-arrest phase is the events leading to the cardiac arrest. And what were your environmental risk factors? And you're looking at if it's hot or cold, drowning, if there are pathological conditions that exist, if they have WPW, long QT syndromes, if they have kind of innate cardiac problems. These are your pre-arrest problems. The no-flow phase is the time that's untreated before resuscitation is initiated. So until we recognize it, nobody does anything. Remember, the majority of pediatric out-of-hospital cardiac arrests are not witnessed, and survival rates are much worse than in hospital because the no-flow phase is much longer to be initiated in out-of-hospital arrest. Now, the big thing is we are doing a problem is that we're not educating our community enough. The study showed also bystander CPR rates were associated with higher survival rates. Unwitnessed cardiac arrest had a 4.6 survival. If they had bystander CPR rates, it went to 4.7. If it's witnessed cardiac arrest, it was 13.1. With bystander CPR rates, 9.4. So the numbers are basically doubled the more we get our community involved in the resuscitation aspect of our children. The low flow state is when the initiation of CPR has begun and the brain perfusion has occurred. CPR is initiated with good chest recoil and strong airway management. Remember, negative intrathoracic pressure is required on the recoil to improve venous return, to decrease intrathoracic pressure, to increase coronary perfusion, and also help myocardial blood flow and resuscitation. If you look at the cerebral perfusion and the cardiac output after ROSC, this is your post-resuscitation phase. So you have the child back, but you have to make sure you're maintaining the brain. So there are things called post-cardiac arrest syndrome, which basically is associated with high mortality rates. And these are hypothermia, so anything over 37 degrees is associated with increased mortality rates. If this patient is hypoxic, if they are hyperventilating, if they're hyperoxic, if they have a MAP less than 65, or they're having ongoing seizures. And we'll pass on the videos for now. AHA basically talks about prevention, early high-quality CPR, bystander intervention, rapid implementation of ALS, and aggressive post-resuscitation care. These are all the key chains of survival. If you look at each age presents with a different rhythm. And you can see if they're less than 1, bradycardia, atrial fibrillation. As they get older, more of a arrhythmia called atrial fibrillation is occurring between the teenage years. So this is more of an awareness of what rhythm you're dealing with based on what age group you have. The compression depth is 1/3 of the chest diameter. In infants, it's 1.5 inches if they're between 1 month and 1 year old, and 2 inches in children if you're between 1 year and 18 years old. Compressions to ventilation ratio, if you're by yourself, it's 30 compressions to 2 ventilations. If you have a 2-person CPR, it's 15 compressions to 2 ventilations. Cuffed tubes are acceptable in children under 8 years old. Of course, this does exclude neonates, and the ratio for compression ventilations in neonates is 3:1. So what's the role of bystander CPR in children? 33% of children receive bystander CPR, which is basically approximately the same as adults, which was kind of surprising. You thought there'd be more of a uptick of compressions associated with children, but hands-only CPR has been shown to be equivocal to chest compressions plus rescue breathing. So basically you have a reservoir of oxygen in the lungs, which can oxygenate the blood through the lungs and keep the body flowing for about 6 to 15 minutes, especially if you can add passive airway too. And gas exchange occurs with gasping in CPR. Remember, gas enters the lungs with chest recoil, and that's why the negative intrathoracic pressure helps as well. When you're working on a code, adults or pediatrics, there's a thing called CPR fraction. And CPR fraction is the percentage of time that you are on someone's chest delivering compressions during resuscitation. You should be in the approximately in the 80 to 90% range for success, and the coronary perfusion pressure is determinant of the best chance of having ROSC. And you need to maintain that to be about 15 millimeters of mercury to maintain coronary perfusion pressure and sustain a ROSC. When you're doing compression rates, your rates should be between 100 and 120. Anything higher or lower will increase mortality rates. And remember, do not lean on the chest while you're doing compressions because you're going to hinder negative recoil, which is very, very important for resuscitation and coronary perfusion. Continuous compressions are essential because for every 1 second pause in compression results in a 1% reduction in the chance of getting a ROSC. It takes 10 compressions for you to begin to perfuse the coronary arteries to the desired 15 millimeters of mercury pressure, and it takes 30 seconds to begin perfusing the brain, which is the reason that the person becomes anoxic. So what's the best way to deal with airway management when you understand that interrupting compressions can cause increased mortality rates? In general, we will go on and cover that shortly, but the initiation is continuous compressions, immediate iGel, or airway management without minimizing compression time or compression delays. Defibrillation, pediatrics, is either 2 joules per kilogram or 4 joules per kilogram. If the initial defibrillation does not succeed, you can double the initiation of voltage. Obviously, AEDs are recommended and can be used for children between the ages of 1 and 8 years old. A lot of people have issues deciding when can I stop a code. And a study was done in Circulation in 2013. They found that increased CPR duration was associated with increased survival and neurologic outcomes. And thus providing CPR for 20 minutes was not futile. And especially surgical cardiac patients had the best outcomes. Probability of survival, if CPR was done for 1 to 15 minutes, was 41%. If it was greater than 35 minutes, it was 12%. And survivors had favorable neurologic outcomes 70% of the time under 15 minutes and 60% of the time even after 35 minutes. So what happens if you do resuscitation beyond 30 minutes, especially in drowned children? What does the information say that? Well, poor outcomes, specifically death or survival in a vegetative state or with severe neurologic disability if you have having a PCP of greater than 4, which we covered earlier. And they studied 160 children with cardiac arrest and therapeutic hypothermia after drowning. And the drowned children whom ROSC is not achieved under 30 minutes of ALS initiation had extremely poor outcomes. And good neurologic outcome is far more likely under 30 minutes, which really speaks to us. So if EMS does not initiate or obtain a ROSC prior to arriving in the hospital, the chance of survival for that child is slim and none. So our job is becoming extremely important, and it's a matter of life and death if we're good at what we do. End-tidal CO2 has been a great marker for resuscitation for adults and obviously for kids as well. A simple thing to go by, if you're 20 millimeters of mercury on your end-tidal CO2 at 20 minutes CPR, there's a much higher chance of ROSC. If your end-tidal CO2 is less than 10 at 20 minutes, greater than 20 minutes of CPR, there's almost no chance of resuscitation. So when patients are causing trouble in your hospital, what do, right? You intubate them. But this has been a big scary thing for pediatrics. A lot of states have gone away from intubation for the pediatric patient because they're uncomfortable with the paramedics' training, competence, and success rates with intubation. But when you look at Airway, cardiac arrest for pediatrics, trauma, and drowning patients, the ABC has not changed. Resuscitation for adults is now circulation, airway, and breathing, but ABC is still the same for these three because these three conditions are directly related and their outcomes related to oxygen becoming part and delivered to the body. So why do we fail at out-of-hospital pediatric cardiac arrest? Well, asystole and PEA occurs about 82% of the time, and respiratory etiology is the #1 factor involved. We have poor bystander CPR rates. Cortical ischemia occurs between 9 to 12 minutes after arrest. As you know, survival rates are dismal. They're rarely witnessed, unknown downtime, and we honestly don't do enough training or are comfortable with this, including your physicians, including your paramedics, and nurses. So you're not alone. And it really can be overwhelmingly, emotionally overwhelming, especially if you have little ones at home. And so it's our initiative to become really good at this. So there's a lot of issues whether we should intubate or not intubate pediatric out-of-hospital cardiac arrest. A couple of studies I'm going to go over here. A comparison of pediatric airway management techniques during out-of-hospital cardiac arrest in the CARES database. They found that Bagvalvemask was associated with higher survival-to-discharge rates versus endotracheal intubation or supraglottic airway. Another study was done in the effect of pre-hospital advanced airway management for pediatric out-of-hospital cardiac arrest, 2,100 patients, and they found that pre-hospital advanced airway was not associated with an increased chance of neurologically favorable survival versus Bagvalvemask only. And to bear fruit to that too, California has banned paramedics from pediatric intubations, and this is debated whether this is right or wrong. When we do have a pediatric intubation, remember gasping during CPR is when the brain is low on oxygen. You initiate Bagvalvemask, and we encourage our paramedics to do intubation or supraglottic airway. The problem with Bagvalvemask is that as you will continuously bag and ventilate a patient, air will go obviously into the diaphragm, into the stomach, which will cause the diaphragm to rise, which will cause an intrathoracic pressure to rise, which will decrease venous return, decrease coronary perfusion pressure, decrease cardiac output, and defeat the purpose of what you're trying to do. Endotracheal intubation and supraglottic airways do avoid these side effects, but after you do control and do obtain intubation, once you think of a theory of permissive hypercapnia. What this is, permissive hypercarbia, is allowing the oxygen level to rise a little higher than normal. And the side effects are really, the studies of this were done in ventilated patients, primarily with COPD. And they found by increasing carbon dioxide levels, it promotes the drive to breathe. Hyperventilation also causes hypoperfusion, and ventilation state must equal to perfusion state. So we'll cover what that means shortly. When you allow the end-tidal CO2 to rise a little higher than normal, it causes cerebral vasodilation and can cause increased intracranial pressure. So if you have a seizure issue, it's probably something to be aware of. The cellular effects, it shifts the carboxyhemoglobin curve to the right, and this increases tissue oxygenation levels. The cardiac effects are increases sympathetic nervous system release of epi and norepinephrine, increases cardiac contractility and cardiac output, may cause arrhythmias. The renal side effects, it decreases urine output, decreases glomerular filtration rate, initiates the release of epi and norepinephrine, and the release of vasopressin. Now, if you remember a long time ago, we used to have vasopressin in our ACLS analogs, and the reason was it kind of increased preload along with the epinephrine to increase cardiac output. Together, that was thought to improve cardiac resuscitation rates. And also decreases systemic vascular resistance, basically systemic vasodilation, which will increase your preload. And these are the control side effects of permissive hypercarbia. Now, the big side effects, seizures, pulmonary hypertension, if you've had head injuries and mass injuries and bleeding, severe metabolic acidosis, elevated intracranial pressure, severe hyperventilation, and sickle cell disease. So if you have those, don't do it. But the most important thing I want you to understand is post-intubation is not to ventilate too fast. The optimal rate of ventilation for post-intubation in most places is 1 every 6 seconds. We modified that, and we made it 1 every 10 seconds. And the reason is, if you have it at 1 every 6 seconds, these are the side effects. You cause systemic hypotension because you're hyperventilating, you're increasing thoracic pressure, and when you're increasing thoracic pressure, you decrease coronary perfusion pressure, you increase free radicals, you also lower coronary perfusion pressure, and you lower cerebral perfusion pressure, and ultimately, hyperventilating, our rate of 1 to 6, which we're currently doing, will increase mortality rates. There are other pitfalls as well. Once you've intubated, there's a definition called hyperoxia. And this was done in JAMA in 2010. And they said if you're intubated, they want you to control your post-intubation oxygen levels. In ICU, hyperoxia was defined as end-tidal CO2 or arterial oxygen saturation greater than 300. Hypoxia was associated with an oxygen level of less than 60. Arterial hyperoxia, i.e. Oxygen level of greater than 300, was associated with the increase in hospital mortality by 40% versus hypoxia and normoxia. So basically, they recommend post-intubation for children should have their oxygen saturation set at 94%. Therapeutic hypothermia has been shown mixed successes with adults. However, they're very beneficial with neonates. Children up to 28 days old showed improved neurologic outcomes with therapeutic hypothermia. It's controversial in children, and 42% of these people do have seizures. However, mild hypothermia between 34 to 36 has shown to improve the neurologic outcomes in adults post-arrest and children. Some places are beginning to do this. They're doing this in Paris. Traffic was so bad they couldn't get resuscitation initiated to a center early, so they started ECMO. What is ECMO? ECMO is basically a machine that provides oxygenated and ventilated blood to the body, and basically it performs the work of the lungs. It's called a veno-venous ECMO. If it does the work of the lungs and the heart, it's called veno-arterial ECMO. And really it's a temporary measure until the heart and lungs can heal potentially well enough, and this is really a bridge to transplantation or a bridge to resuscitation survival. So ECMO basically takes your deoxygenated blood from the body, puts it through an oxygenator, and also removes carbon dioxide and putting fresh oxygen back into the body. And this may be something that might be beneficial for pediatric arrest too now. So overview of our pediatric arrest.
So we'll talk a little bit about Polk County Fire Rescue. We're a large system, 105th largest in the United States. We cover 2,010 square miles. We have a population of hitting around 675,000. It's a fast-growing population as well. We are 39th largest fire department in the United States, 4th largest in the state of Florida. We respond to over 116,000 calls, 911 calls a year, and had just under 85,000 transports for year 2017. We have 5 local hospitals in the county. with one hospital being specific towards pediatrics. And we do have integrated 911 emergency medical dispatch for over 800 of our pre-hospital providers. A couple other things that aren't on that slide that we should discuss is that Polk County Fire Rescue provides all of the 911 ambulance services for the entire county. So Polk County Fire Rescue is the only one that transports patients from a 911 call within Polk County. We don't have any other services to provide that. We have 37 ALS ambulances and over 15 to 17 ALS engines that provide advanced life support care for the citizens. Additionally, we provide the medical oversight for 3 larger city municipality fire departments to also provide ALS engines. But I think the important thing is, what I'm trying to stress to you, is that we have one medical director, Dr. Banerjee, who's speaking now, and one set of protocols. So our providers, there's no multiple sets of protocols out there, different types of way to treat our patients, things like that, which I think lends itself to a more successful outcome for the patients. So all the citizens within our county are being worked on, whether it's by Polk County Fire Rescue or Lakeland Fire Department or other municipalities, being worked for under the same medical direction and the same protocols.
So if you looked at our data in 2012 and 13, we basically killed everybody. We didn't mean to, but we did. So the reason was we weren't very proficient. We only had 30 cases a year. All our medications required math. The inherent stress of dealing with pediatrics, which we were not comfortable with at all. We're using a length-based tape for years without any improvement of survival. We're using a non-rebreather primarily for airway management. Rapid ventilation rates, if we did intubate, 1 per 6. We pick the patients up and take them to the ambulance, probably more so than anything because we were scared. We didn't want to show what we didn't know in front of the people who were panicking in front of us. We had really poor community awareness, poor community integration, so we looked at ways we needed to make changes. So if you look at 2012 and 13, we did the traditional early transport, scoop and run. We started treating in the ambulance, probably more so from fear than confidence and understanding. We did non-rebreather, some Bagvalvemask. We used a length-based tape, and everybody died. We looked at the focus change from 14 and 15. We started staying on scene, early epinephrine, wanted to have a definitive airway, either endotracheal or supraglottic. We switched to the HANTEVI system, and we started community education. Now, we looked at the Braslo tape, and we looked at things we could do and what were the mistakes we were making. Simple things like looking at Braslo Blue, which means you're 20 kilograms, you're running about a 5 to 6-year-old child. You're giving the endotracheal dose of epinephrine, 2.1 milligrams. Fentanyl, 63 micrograms, 3 times higher than you should be giving. Versed, 6.3 milligrams, which is 3 times higher than you should be giving. So a lot of it is you're scared, you're not informed, you're not comfortable, you're not educated in it, and more importantly, we're giving the wrong meds, or the wrong dose of the medications. So we looked at a better way of doing this. HANTEVI system was one part of this. It made medications easy to do. We applied simple charts were there for us to copy and use the doses that were written. It integrated with our protocols. It was used as a reference guide for pediatrics care, and it was simple, effective, and really enjoyed by our crews, which was quite a pleasant surprise to me. And the HANTEVI is this. Do you want to?
So it's based on a age and a ideal body weight for all age groups. So you just look at your hand, it's 1, 3, 5, 7, 9, and you can just go 10, 15, 20, 25, and 30. And it'll break down the medications to make it really easy to remember. So for a 3-year-old, you if you're giving epi, you would just move the decimal over, and you know they're 15 kilos, so you're giving 1.5 milliliters of the epi. So you can do your math ahead of time. You get your information from dispatch. So training our paramedics and getting them on board with this and giving them that confidence that they don't have to do the difficult math on scene made it a lot easier for them to stay and work a pediatric cardiac arrest on scene instead of that traditional load and go because we don't know what to do, more about approaching it like an adult. You know you're giving a milligram to an adult, so you just walk in the door knowing what you need to do.
If you listen to 911 dispatch tapes, the obviously and rightfully so upset caregiver, parent, when they ask, a dispatcher will ask the weight of the patient. If they ask the weight of the patient, they never know the weight of the patient in that time of emergency, but they always know the age. So the nice thing about this is that you almost always get an accurate age by dispatch en route to the scene. And with the age, you can correspond their weight. And then, if you have the ability, even preload your medications en route to the scene of the call.
So we decided to stay on scene, and we thought scoop and run was wrong in pediatric hospital cardiac arrest. In fact, it's wrong for all patients. When we run on scene with a 70-year-old man, we don't sit and let me pick him up, let him take him back to the ambulance so I can initiate care. You initiate care on scene. Same thing with children. By taking them into the ambulance, you waste precious time. You basically kill the parent's confidence because you obviously don't know what you're doing. It kills patients because you're delaying care. And ultimately, you must stay on scene and begin immediate interventions just like you would with adults, which means Bagvalvemask, early epi, early endotracheal intubation, stay on scene. We pre-filled medications, which was obviously part of the program as well that you have. Some of the medications are pre-filled in the boxes that are provided. So once you went on scene, you could immediately pull out the age, the dose, and initiate IV or IO medication. And as Chief Fatone just stated, if they were known what age they were prior to arrival by dispatch, you already knew what age they were, what dose you were going to use, and everything was already set on scene to administer, or no calculations were needed. Remember, pediatric PEA and asystole, we looked at the different things that were components of it. We looked at basically having continuous compressions at 120 per minute, CPR fraction rates greater than 80%. We looked at a PEA bundle for pediatric arrest as well. Based on the PEA rhythm, was it a wide or narrow complex? We wanted to get a definitive airway, Bagvalvemask to IGL or endotracheal intubation, bicarb if they're acidotic or prolonged downtime, any possible chance of overdose or awareness or surroundings of a paraphernalia that would indicate that. We'd give Narcans. Children would get 20 cc per kilogram fluid boluses. If there's any renal issues, we'd do calcium chloride. Obviously check sugar, D10W for pediatrics. If it's a traumatic arrest, it's obviously needle decompression. And it really goes back to the initial H's and T's. And if you look at all the H's and T's with the PEA bundle, we're basically fixing almost 9 of them. The only ones we really can't fix are basically your pulmonary embolism, your myocardial infarction. Every other scenario was going to be addressed by the PEA bundle. So we didn't know what caused it, but we would try everything we could to fix the PEA bundle. And the wide complex versus narrow complex, if it's a wide complex PEA, you're thinking of hyperkalemia, a metabolic problem, pump failure, where you're thinking of a narrow, you're thinking of tamponade, tension pneumothorax, pulmonary embolism. So that kind of gives you a different way to approach PEA. Again, airway management, early intubation, immediate Bagvalvemask, IGL within 5 minutes, 1 breath every 10 seconds post-intubation. After ROSC is obtained, wean the targeted oxygen saturation down to 94%, mild permissive hypercarbia, and this is more so done to slow your bagging down. So if knowing your target's 40 to 50, you're not going to blow off that oxygen and the carbon dioxide as fast, and basically slow your rate mentally down to accomplish that at 1 every 10.
So these are the numbers of our pediatric cardiac arrest data over the years. You can see prior to implementing this system and training our paramedics to stay on scene, we had a 0% survivability for pediatric cardiac arrest. In 2014, we, like Dr. Banerjee said, we kind of revamped the system and looked at different ways to approach pediatrics in the field. And our survivability, it jumped up to 71%, and we've been steadily trending higher over the past few years. Currently, for 2018 through June, our data showed a 78% survivability rate out of the 16 pediatric cardiac arrests that we've worked. We get ROSC 56% of the time in the field, so that just really stresses the importance of what our crews are doing and the hard work that they put into this. It all kind of goes back to the training and building their confidence to just work, to stay and work a pediatric in the field before they start transport.
If you look at our overall breakdown, we're kind of similar to the national averages. Asystole was 73%, PEA was 13.5%. Our total of PEA asystole was 87% at the time. If you looked at VTAC, 0.7%, and sinus TAC was 12%. We had 52 drownings, which compromised 39% of our patients. Our intratracheal intubation rates and success were 1 out of 13, or 7.6%, in 12 and 13. And in 14 to 16, our intratracheal intubation rates went up to 22%, so 3 times higher. Also, this did not include our supraglottics, but just directly endotracheal. Survival of discharge in 12 and 13 versus 14 and 15. We found significant improvements, as you saw. We had the bundled approach with early epinephrine, aggressive airway management, improved epi times. In fact, we lowered our epinephrine times of administration from 16.5 minutes to 7.25 minutes. And this graph basically shows the drop and the ROSC and the survival intact rates because of dropping the time to epinephrine. If you look at the survivors, survival of intact between 12-13, 14-15, 16-17, again, as you see, the numbers have increased significantly in ROSC and survival rates. We've been published a lot of places. In fact, we're very excited that we just got accepted for publication in the Journal of Resuscitation. We have an electronic version waiting for the final version. I can't thank Dr. Pepe, Dr. Ganti, Raf Patone, Polk County Fire Rescue enough for allowing us to do this, and our crews, most importantly, for all the hard work they did, because without them, this wouldn't be possible. So how do we compare the national and international levels? 138 out-of-hospital pediatric arrests were measured in 2015, retrospective analysis of children under 19 years old. This was done in New Jersey from 2009 to 2014. 66 patients, only 6 had ROSC, which is 9%. Survival was dismal. In fact, it was so dismal it wasn't even listed. If you looked at international outcomes, they were Pan-Asian study, 974 children, bystander CPR rates were the highest in Korea, lowest in United Arab Emirates. Overall, 8.6% of children survived a discharge, adolescents with the highest survival rates. 3.7% had good neurologic outcomes of 1 or 2 CPC scores. Pre-hospital advanced airway was positively associated with survival to discharge in children under 13 years old. So the big positive outcome indicators were being adolescent, bystander CPR, and initial shockable rhythms. So what's the bottom line in this? We chose the hand-Tevi system because it was adaptive to our individual needs. And as a medical director, we have certain things we want, and Dr. Antevi was able to put up with my complaining and asking and modified our protocols to fit his system. It was able to lower the no-flow and low-flow states. It eliminates need for calculations. It basically treats them based on age, and the dose is already there. It allows confidence in the pre-hospital providers. It minimizes errors because you know based on the age, what dose you're giving. There's a consistency of care. It's very simple paramedic training. And best of all, it's millennial proof, and there's an app for that. So the summary of our success, there's no one silver bullet. It isn't just one system that works. It involves early intubations, early interventions with epinephrine, Bagvalvemask, controlled ventilations post-intubation. The system is easily reproducible and consistent. It develops System 1 thinking. It also entails continual training, continual community education, and yes, it's easy to adapt and integrate into your EPCR as well. So the mnemonic is A, B, C, D, E. So you arrive on scene, you initiate Bagvalvemask, begin compressions, drill or get an IV, and administer epinephrine. All this needs to be done within 2 minutes on scene. We trained our crews in that, and if you want, there's some videos that we can send you if you need that. But this kind of summarizes the presentation, and I guess we're open for questions, AJ.
Yeah, let's go back to ventilations. You go to that once every 10 seconds. How do you time that out? Is there an incident commander that's doing that to make sure it's not overventilated?
No, we just basically really drill it in training. It has to be 1 every 10. And we use kind of end-tidal CO2 to be a marker because when you hyperventilate, your end-tidal CO2 will become really low. In essence, we're asking them to keep it a little higher, which will slow down the mental ventilation rate. But this is all training. We're basically really drilling into them 1 every 10 seconds.
And what are you trying to keep that end-tidal CO2 level at?
Basically between 40 and 50.
Okay. And then how about the depth? How do you control the volume of the ventilation?
It's really just one good squeeze on the bag. That's all it is. And we also have a ventilator too, and chest rise. Yeah.
You think there was a question you had? Do you think there'd be any value in a flow adjustable bag that could limit the amount that you give to a kid?
Yes, I think it would, depending, especially if you could tailor it to the age, weight, size of the children, limit basically your tidal volume that you're administering.
Okay, and let's go back to epi. So you're giving epi once every 7 minutes, is that what I saw?
Yeah, we dropped from 16.25 minutes to 7.25 minutes of epinephrine. In fact, it's dropped to 5.25 minutes in the last 2
What you're saying is the time it takes for us to give the first dose was the drop.
Right.
Yeah, we're doing epi every 3 to 5.
Every 3 to 5, but you're starting it a little bit earlier than you normally would have.
The pit, and we're really trying to work on approaching and develop a pit crew approach to all of our cardiac arrest. And so what Dr. Banerjee was saying was that we've reduced our time to first dose epi from the 16, 17-minute mark down to the 5-minute mark.
Right, 5.25.
Okay, and let's go back again to the drowning victims. Are they included in all your data, or are you finding that the drowning has to be handled separate from the rest of the data?
No, we just include everything. We'd rather be completely transparent with everything we have.
But you're finding that drownings are harder to resuscitate? Is that what I'm reading?
No, they've actually gotten better because we've had bystander CPR education, and a lot of times they've initiated the care, and by the time we get there, we start initiating care, and we seem to get Ross back quickly.
With the pediatric drowning, Polk County, lots of water in Polk County. 1, Florida, so everyone has a backyard pool. 2, we have lots of lakes, canals, so we tend to have a lot of drownings, unfortunately. I think one of the big success points in the pediatric drowning is to be real aggressive with the airway, using that use advanced airway, whether it be an endotracheal tube or what we use as an eye gel for a supraglottic airway. I think that's one of the key successes for specific to the pediatric patient.
And you go down and use the absolute smallest eye gel wherever you can?
We actually carry pediatric idols now, so we have all the way down to very small ones for infants. So for training, we really train our paramedics, try to get ET tube, and then if you're just not getting it, then they can defer over to the iGel, but we do carry pediatric iGels.
Okay, here's another question. Will permissive hypercarbia also stimulate the drive to breathe in a COPD patient?
Yes, the studies were done, actually initial studies were done on ventilated COPD patients, and yes, it does.
Okay, another question here. How would Narcan help once the patient's in cardiac arrest? We still need to restart the heart, and Narcan won't do that, is the question.
Well, if they are an opiate overdose, by reversing the hypoxia, that would initiate one of the treatments for PEA arrest. So yes, obviously we're going to need to do compressions and epi, but one of the reversible agents are Narcan if you're in a drug overdose session.
Okay, and have you found in any of your peds that they were, the result of their cardiac arrest was maybe mom or somebody else allowed them to get into narcotic?
There was one case.
One case. Okay. Are your pre-hospital EMS crews PAL certified?
Yes.
Question? Could you hear me?
Yeah, I'm sorry, yes. We do PALS with all of our paramedics, but we look at the hand-heavy as a augmentation of that training.
Yeah, and I think what you're saying is it's nice to go through PALS, but you've actually significantly modified your approach, and hand-heavy is a big part of that. Most systems that I know that have switched over to hand-heavy are very pleased with it. Well, how did you get your responders to buy into working peds arrests on scene? That was a question that we got from UT Health in San Antonio.
Yeah. Listen, one of the I'd be lying to say that we do enough pediatric training, because we can never do enough pediatric training. But it's a matter of having a very strong medical director that pushes this out to the field, that explains. Dr. Banerjee meets with the crews often and answers questions for them. It gives them the data, explains whenever we do a change in protocol. We try to get that information out to the crews of not just that we're doing it, but why we're doing it. So I think it's just a cultural change, and we have problems like all other departments with retention and retirements and getting new people in. So we really got to hand it to the crews. We don't do as much training as we want to, but any way that we can get the message out to them, we get that message out to them. And you just kind of got to, I think the results of what we've been doing once we've enacted the hand-heavy system has helped develop that cultural change and lend itself to our success.
Yeah, and I think a comment I want to make, certainly my work as well as JEMS, we've found going around to Rialto and Lincoln, Nebraska, and all these other places that when the culture changes, then the crews get a new enthusiasm and begin to realize and actually come back and tell the on-duty chief that they're sorry they couldn't resuscitate. It becomes an expectation now that they're going to do better because they have a better way of doing it. Have you found that?
Yes, absolutely. I mean, I have people tell me, hey, I got 3 arrests. We actually, it was like last 2-3 months ago, we did hand-heavy training for a day. Within an hour of the training, we had 3 pediatric arrests. Within 1 hour of that training, and I think 2 out of 3 kids survived. 1 did not. 1 became an organ donor. But it just shows the power of training. It's a culture change of you wouldn't treat an adult different than you would a pediatric patient. So why not? You don't pick a 70-year-old, 300-pound guy up taking the ambulance, work him on scene. Same with the kid. You work him on scene. You treat them exactly the same. They're just
and
smaller.
Have you been able to win over the ER directors? That was one question somebody had. Are they supportive and realize now that you're working calls longer in the field and getting better results? Do they feel that and cooperate?
Yes, but again, you have to have it helps to have a real strong medical director who's really involved, not only with the department, but also with the hospitals that we serve. We have monthly meetings with all of our hospitals, QA meetings, and we discuss everything on a monthly basis with them. So the involvement of the medical director, I think, is key to this success, as well as your interactions with hospitals.
Yeah, and obviously I'm a cheerleader for your program, and certainly know Dr. Banerjee well, and linking up with Dr. Pepe's attitude and Peter Antevi's is that you think outside the box, and those programs that are thinking outside the box and are really championing them are doing a heck of a lot better. So you're to be commended. Now, there was a question in here about does your method decrease the time to defibrillation?
Well, we're initiating therapy earlier on scene. So if you initiate therapy, obviously you're going to have earlier defibrillation. But if you looked at the primary numbers, they're not defibrillatable causes in pediatrics. Adults is different, but basically less than, I think, 10% approximately were defibrillatable, if that's a word. But realistically, it's really not an issue with pediatrics more so than adults.
Okay, and what's your training schedule look like for your pre-hospital crews? How often do you hit them with training?
Well, we try and get 2-hour refreshers. We do, for any new employees, we do initial hand-heavy training with them. We try and do 2-hour remedial training. We're trying to get down to every 6 months.
Okay, and then do you critique every pediatric code with the crew that was involved?
Every pediatric code is QA'd, and feedback is given through the QA process. But many times the crews now reach out to the Office of Medical Direction, reach out to us, and let us know that they had a pediatric cardiac arrest or a pediatric patient, and and so actually it's kind of a reverse QA where they're actually call us and interact with us and begin the initiation.
Okay, and there's a couple questions here that I'll ask, but before that, there's a couple questions about the slides and your contact information. That'll all be on the downloadable set that we're going to have up. And the question is, can we also put a link in there for your videos? Because quite a few people want to see the videos.
Absolutely.
Okay. What's the cutoff age for the 1-to-10 ratio for ventilations?
There is no. We do it for adults and pediatrics.
You do. So you're finding what other programs are is there's a lot more, emphasis on compressions and less on ventilations.
Right.
Am I reading that right?
Correct.
There's comments on access to guidelines, AHA versus Medic, ASHE, and Red Cross, or do you just follow ILCOR?
ILCOR is primarily the main resuscitation guideline. Obviously, other ones are your basic guidelines, but I think a lot of it has to be addressed physiologically more so than routinely. And I think there are things that are not necessarily in AHA that we're doing that have shown much higher success rates than what AHA is doing. There's a lot of great things AHA do that we take from them too. It's a great standardized program that everybody can use, but I think there are ways we can make it better because if you look at the national average for survival for pediatrics and adults who all follow AHA, ASHE, and all the above is pretty dismal. And I think by changing things, looking at things a little differently, thinking outside the box, doing physiological medicine instead of cookbook medicine, our results have shown that there's a significant improvement in survival because of that.
That's great. And, I like your kind of almost a mnemonic with your entitled CO2 greater than 20 minutes. And you're finding, as Brent Myers and others do, that there is no golden cut the code off after 20 minutes, correct?
Correct.
Okay. A lot of comments about you are using the iGel. And is there any difference between endotracheal intubation and iGel that you found?
iGel is obviously a 99% success rate, I think. Intratracheal intubation, which is shocking to me, is higher in pediatrics than it is adults. I think the first pass intubation rate for pediatrics is about 80s. It's only 75, I think, for adults. So they actually are doing a much better job intubating children than they do adults, which for the life of me I don't get. But if they don't get it the first time, they immediately go to iGel. It's just easier to do, and it has basically a 99% success rate.
Okay, but is your protocol that they try intubation first before going to the iGel?
Correct.
Okay. There's a lot of people in here applauding you, and I think that you've nailed it. The same thing that other people have nailed is you thought outside the box, you won in your crews, the culture has changed. You're not relying on a tape system that's giving you inaccurate medications, and the Hantevi system is putting you right on the mark. But go a little bit more about what the crews are thinking and doing on the way to the call, because I know that that's a big part of this story.
Well, I just think that they're just a little bit better prepared and a little bit more at ease. The more comfortable they are going to the call, due to the ease of the system that we put in their hands, I just think that they're arriving on scene in a more relaxed state. We are also starting to initiate future training into a pit crew approach. There's a little bit of that already in the basic Hantevi program, but we're looking at expanding it. I just to answer that question, AJ, I just think the idea is that the more comfortable they are in the treatment of pediatrics, the more confident they are once they get to the scene, and the better outcomes that we're getting.
And my goal basically is to have them as comfortable with an adult arrest as they would a pediatric arrest. And once I've achieved that, we're good.
And are you using PEEP with your BVMs?
Yes.
You are? Okay. So that's an important part of this whole thing as well. And do you have a goal for how long you work a patient on scene before you start transport?
A minimum of 10 minutes. We want them to stay on scene for 10 minutes. And with pediatrics, it's definitely about, getting compressions, epi on board, and securing your airway prior to scooping and running.
Okay, and you talked about active CPR training. Obviously, everybody looks for that golden nugget. Are you using any of the apps like Pulse Point in your county?
We are going to be initiating Pulse Point in the near future. We have about 3 of the 5 hospitals that are using it for their operations, and we're going to be tying in with them here in the near future.
All right, and do you go right to an IV or an IO? What's the preference on your protocol?
For pediatrics, they do a quick look over, but I'd say the majority of the patients receive the IO.
Okay. And how many ALS providers are dispatched to handle an arrest?
Generally, we'll have an ALS ambulance with 2 personnel, ALS engine, or a BLS engine with 3 personnel, and more times than not, a battalion chief as well, paramedic battalion chief.
Depending on location, you'll usually have 1 paramedic, if not 2, depending on the zone that they're in.
Okay. And we're back to the Airway again. People want to know what made you go to iGel. Was it the field crews or EMS control?
Well, we used to use the King tube. The problem with the King tube was there were some studies showing potentially there was some carotid artery compression. The other thing was that the failure rate was maybe like 2%, but it seemed a little more difficult. The advantage was that there was an oral gastric tube there that you could use, but we weren't using it enough. So when we switched to the iGels, there is an oral gastric tube for that too. It's basically an LMA that's very simple to learn. I think if you do it once, your learning curve takes about less than 30 seconds. And I think it's something you can learn really quickly with high volume providers. You need minimal time to learn. This is the simplest tool that I found, that you can get a definitive airway accurately.
Well, there's a message here that I'll cryptically say goes to Carla, and she said that iGels are millennial proof, and she has a true story. So email me separately. I'd love to hear that story to be able to understand what you mean by that. I think that's all the time we have, and you guys have been great. Again, want to point out that this is going to be archived. You'll certainly have the opportunity to download it. Please share it. Others are asking, could this be made a part of PALS? And, you know, the more systems that adopt kind of your approach, the more people that are stuck in the 50s are going to change their approach. We're finding a lot more people are moving to new methods and new bundles of care and mechanical CPR and a lot of things that people thought were just not important. So I think that we just continue on, improve our systems, and others will follow us. Thanks again for participating. Thanks to our sponsor, Laerdal, for their support. This is a massive turnout today for this, which shows that it's a very interesting topic and one of great concern. And I certainly hope we've influenced your practices out there. Don't forget to complete the evaluation to receive your 1-hour CAPC-approved Con Ed. You're going to get instructions on how to obtain your certificate within 3 to 5 business days. It's going to be archived. We'll have a link on there and contact information for all of our speakers today, and we'll also have the video. So thank you so much for attending, and we hope to see you back again for another great JEMS webcast.